Thank you so much for your continuous patronage. We are moving on to the last session of this conference, Potpourri, tackling a combination of topics related to neonatology. Our speakers for today's session are from the UAE and the USA, and to chair this session is Dr. Ayman Ramani. Dr. Ayman is a highly regarded pediatrician and has received several awards and recognitions from American Medical Association, the American Academy of Pediatrics, and at Tawam Hospital. One of his many clinical achievements is expanding Tawam Hospital, NICU, to level 3+ unit, which provides tertiary services to all Al Ain region and serve as a referral center for the UAE for neonatal surgeries and metabolic disease management. Good evening, Dr. Ayman. I hand over the session to you.
Thank you very much. So we're moving to the home stretch with the last session of the conference that I am expecting to be a very informative and very up-to-date. It's my pleasure to introduce the first speaker of this session, Dr. Hafiz Ibrahim. Dr. Hafiz is a consultant physician in the Department of Neonatology at Corniche Hospital in Abu Dhabi, UAE. Dr. Hafiz, he's have many interests in other than neonatal clinical neonatology, including medical research, medical safety, quality improvement, and he has led many quality improvement projects in his hospital, Corniche Hospital, and throughout his career. He has multiple publications in peer-reviewed journal, and he has presented in national, international meetings, where he also worked. In addition to that, in Corniche Hospital on leading medication safety project in newborn infants. And he also chair of Hospital Infectious Disease Committee. Dr. Hafiz will share with us his thoughts about quality improvement approach to reduce infections in neonatal intensive care. Please join me and welcome Dr. Hafiz Ibrahim.
Thank you, Zandy, and thank you, Ayman, for the kind introduction. And a big thank you to the conference organizers for letting me share a part of our infection reduction journey at Corniche Hospital. So I've got no disclosures. This will be the content of the presentation in general. So when you've heard all the other speakers throughout the last 3 days, and we know outcomes in neonatology are continuously improving due to the new medications available, new technologies available, and a new outlook to how we treat these infants. And survival is improving world over. But what's happening with that is there's some associated increase in short-term and long-term morbidity, and infections always comes up as one of the most important of that, contributing to both morbidity, not directly of the infection, has a lot of effect on neurodevelopment, eyes, lungs, you name it, and it causes problems. And of course, one of the leading causes of mortality world over. So I'm not going to delve too much into this. There's early onset and late onset infection. Generally, for surveillance purposes, we call early onset within the first 3 days. It's linked to maternal infection. There's very little we have control over there, apart from prophylaxis for GBS, which is now being adopted world over. It's a late onset infection, which is usually hospital acquired and is linked to infection control measures. And these are potentially preventable, not always, and we can control some of the factors in that. So the burden depends on which part of the world you are. Some parts of the world kind of reporting up to 50% of very low birth weight infants catching an infection after the first 3 days. In the NICHT network, I don't have the most up-to-date data. The last published, they said 25% of the very low birth weight infants in the NICHT network was getting an infection. And in the developed economies all around the world, it has been reducing over the last many years. One of the studies which Dr. Ayman's group was involved, which is published in the latter half of the last decade, which was a multi-center trial in the Gulf region, showed that in the Gulf region, the infection rates are relatively still high at that time, around 56 per 1,000 admissions. And we've also seen seasonal variations, but nobody's been able to pinpoint what causes those seasonal variations. A brief introduction of the center which I work in, Cornish Hospital. It's one of the largest neonatal units in the UAE. We used to be quite busy till a lot of the other units in Abu Dhabi opened up till 2014. We used to have up to sometimes 10,000 deliveries per annum. It has reduced to around 6,000, but we still have a significant number of admissions to the NICU because of the complexity of the deliveries we deal with there, being one of the tertiary referral centers. So we have anywhere between 900,000 admissions per year. And what happened is 9 years ago, we were a relatively small unit and we were working well over capacity all the time, and they decided, let's go up from around 40 beds to 64 beds officially with increase in space and nursing. And what happened, bingo, within no time that was filled up as well. And we were constantly operating above 100% capacity. So as I mentioned, the complexity of the cases we deal with here are high. And we are benchmarked internationally and locally through, so internationally we are part of the WARN network, and we look at our data and compare it to the other units on WARN, similar units. We have internal benchmarking and also within SAHA as for infection KPIs. This is just showing you what our occupancy rates are like. So pre-2013, this was our official cot capacity, 42. Then we went up to progressively 64. We were never fully staffed for that, but always, because of the nature of the work we do, we are invariably above 70. So we are more than 100% census most of the time. And we know that once a unit hits about 80% occupancy, all the adverse outcomes start to show, including infection. And we are a bit lumbered with that, not much we can do because of the way healthcare is organized within the UAE. We just deal with it and get on with it. And this is in the last few years, it's pretty much the same picture. Now, this is where we were in 2014 with regards to infections. So I had just joined the unit at that time, and our then chair showed me these pictures saying that on WARN, we were well outside the kind of interquartile ranges for all late infection parameters. And he said, can we do something about it? Foolishly, I said, yeah, let's give it a try. I didn't realize how much hard work it was going to be. So we launched a continuous quality improvement initiative since then to kind of tackle these infections. It's ongoing. Infection is not something you kind of reach a point and let up on it. You have to be constantly vigilant, because the moment you take your foot off the pedal, it comes back. So we are continuing to do what we're doing, and I'll share the data of what we've gathered over those 6 years. So these are various definitions of QIP. It's essentially shifting away from old ways and moving towards a new way of problem solving and systems to adapt to evolving challenges. And that's what we do day in and day out. So why would anybody do a QIP in your unit? So these are the general things. So patient safety, to reduce complaints litigation, improve satisfaction, financial. So when you put infection there, it ticks all the boxes. So if a baby gets an infection, parents are unhappy. They might say that you gave the infection to the baby. They'll be unsatisfied with the service. And each infection costs a hell lot of money per baby. It shaves off a good margin of the DRG you get from the insurance companies. So for us, there might be various triggers for starting a QIP. For us, it was a Vermont-Oxford comparison, and also the realization that we did have a lot of infection going on from the trends we were seeing in our risk management committees. And also the morbidity and mortality data, infection kept coming up as the main contributor of deaths on a unit at that time. So just briefly running through various methods and styles of QIPs. You have the PDSA, that's a Plan, Do, Study, Act, and you have the RADAR. These are all tested ways of just doing the same thing. Then we also have the other two which came in from industry, which are kind of adopted in some aspects of healthcare. So we mainly follow the PDSA model in kind of initiating quality improvement programs for infection. So when you look at quality improvement, you have to look at lots of things. Structural, what are the availability of your resources? What are the management systems? What's your policies? And even if you have all those, what is the actual process of delivering healthcare? And then you look at the outcomes and then decide what you want to tackle. And now we have the concept of continuous quality improvement, as I mentioned. It's a continuous process. You don't stop once you achieved. Then you ask yourself, where do we go from there and improve even further? So when we started this project, so I was new here, and so we started doing some scoping exercises. So me and part of the team which I put together started flying the wall observation of what was going on in the unit in terms of hand hygiene, central line care, line access. We went around the unit interviewing existing team members who've been there for a while, asking them what do they think is the problem which is contributing to high infection rates. And we had kind of multidisciplinary scoping sessions, a few of them, to take feedback from both medical and nursing staff, and also emails. So that lasted for around 3 months, and then we focused on certain things which we needed to. We put together a core team, which at that time was one consultant, which was me, one specialist. Since then, we included more specialist doctors, the nurse managers, nurses, nurse educators, and somebody from quality improvement. So we started looking at the data and we started formulating action plans. And we assessed the problems in these 3 domains. So when you look at structural issues, Cornish Hospital is 40 years old. It was designed for 3,000 deliveries per year. And we were triple of that at the time when we started tackling this problem. So if you look at both American, British, and European recommendations, the floor space you need per baby, including all the storage areas, is around 14 meters squared. For us, with even our licensed cot capacity, it was at best 8 meters squared. And when we hit our more than 100% occupancy, we were far below what was recommended. So anybody who's visited our unit will see babies all over the place. Not that we want to do it, but we have to do it because of what is available around. Then we looked at our census. There's very little we could do about that. We started partnerships with the hospitals within the network and also the private sector to say, once we are well above capacity, we start moving babies out who are stable enough. But very often we meet resistance from parents about that, saying that we came to Cornish Hospital for a reason, we want to stay here. Not an easy one to tackle. Then storage area for neonatal equipment, they were being stored everywhere, including the corridors, and of course that was getting contaminated. And staffing, we all know nursing staff are the backbone of our unit. And we know that one-to-one nursing significantly improves in all outcomes in newborn infants when they're in intensive care, less so in the high dependency and special care areas. In 2014, for a licensed cot capacity of 64, we were short of 39 staff to even man that. We have caught up since then, but we are still short because of the high turnover of staff in this region of the world. And also, there is again about qualification and specialty, saying that are they neonatal trained and qualified? A lot of our nurses came from general background of pediatrics, they were not, and we trained them up. So if you look at the BAPM recommendations, they say on a neonatal unit, 70% of your workforce should have specific qualification in neonatology, but ours only 20% had, and we put in internal measures, which was already ongoing at that time and strengthened further by our extended education team to kind of train them up, do competencies and sign them off. And the structural issues were all highlighted to our high management, saying that this is an issue and they need to think about long-term planning on these issues. Policies, we all have policies, so we checked, are we lacking any policies? We had a hand hygiene policy, we had a central line policy and bundles, isolation policies, antibiotic policies, policies for cleaning and waste, excellently, very well-written policies, but there was a complete disjoint between what was in the policy and the care delivery. Most of the times, these were tick box exercises without proper monitoring and delivery. And some of the metrics which were being used were not accurate or fit for purpose. So at that time, our infection control practitioner was collecting the data and was presented at infection control committees and everything. But the frontline staff on NICU were not aware of that data. Then in terms of hand hygiene, as I said, there was a policy in place and the infection preventionist audits are showing a very high rate of compliance, somewhere in the 98 to 98% mark. But a fly on the wall observation revealed a different story. People were not compliant, and non-compliance was widespread. One of the things which we noticed, it's human nature. It's easy, you do it. If it's difficult, you don't. The access to hand gel. So most of incubators have these holders which have been missing for a while. Hand gel was stored in our busy NICU spaces. So people kind of cut corners when they were busy, sometimes forgetting to gel their hands. And we had residents coming in from our sister hospital to do postings there who are not properly oriented to infection control policies and not adhering to hand hygiene techniques. And parents, again, they're integral part of what we do, and their training and monitoring was not happening at all. And people are afraid to kind of approach parents and tell them, do your hand hygiene in this way, and you have, or if they hadn't gelled their hands. And we were kind of encouraging the staff to stand up and be brave and do it in a polite way to kind of enforce this. Another bane of my life, mobile phone use in the clinical area, it was widespread. This is one of the most dirtiest pieces of equipment we carry around. People are leaving it on patient care surfaces, handling it all the time. And there was no publicity of hand hygiene, not even a single poster on the unit saying this is important. Look at central lines, bundles were in place, and as reported, the compliance rate was very high. But when we actually looked at it, it was just paper compliance in terms of the tick boxes. So what was happening was the doctor used to do the procedure, the nurse assisted. At the end of it, they just ticked the boxes and submitted it. And there was no empowerment of our nurses to stop the procedure if our medics breached any of the infection control measures in that bundle or the bundle monitoring form. And there was no standardization of how we fixed the lines. Everybody was doing what they learned in their previous place of work, and that was a problem. And the use of antiseptics was another issue as well. We had 0.5% chlorhexidine, which is on a tiny little stick which didn't cover the entire skin area, and we looked at that as well. And throughout the day, our nurses were having to break into the line multiple times, once to hang up the TPN, the next time to hang up a dopamine, it might be insulin, and that had been going on for a while. And this is controversial, even within the Sahar network, we discuss this a lot. The duration the lines are being left in. I know the large data sets from the US do suggest it doesn't matter, but we have to look at what was happening at our end. So this is some of the problems we noticed. So people are using this stick to clean the below 28 weeks, and they were rarely covering the skin area which was being handled at the time of insertion. Tiny little drapes were being used with a lot of the bed being exposed. The tick box exercise was happening, and all these fluid changes, the fixation, the hub was exposed quite a few of the times, and people fixed the line where they deemed fit. So again, about the data, as I said, the data which was being presented did not actually reflect reality. And there was a general feeling that everything was being done, we can't do any more, and accepting status quo. So we put together this team called the Neonatal Infection Team Task Force, and we decided to challenge the status quo. So we started with monthly meeting and said that we have to influence change, standardize things, publicity, education, collect data within the unit and kind of publicize it and go through PDSA site to see where we are getting at. So structural changes through our management at that time, we acquired one extra room in an adjacent ward to kind of decant our low-risk SCOBU babies so that we're not crowded on the main unit. Our staff recruitment continued to improve. We are actually currently in the 170s mark, so hospitals and Sahar supported us in a big way in achieving that. Storage area, we acquired a storage on a different level where all incubators and equipment were stored and brought in only when needed. The incubator cleaning, which was happening, the CSST was brought in-house to kind of monitor it more closely. And there was continuous education. So we introduced what's called the lesson of the week. So what we do is at every handover, we read out, this is what we need to do. So just to send out message to staff. And that was continuous for the first year. We also sent out emails with our data as we got it so that people realize where we are. And this is just Dr. Akuma, my colleague, reading out the lesson of the week on one of the handover sessions. Data. So this was what was coming from the ICP team with a very high compliance in hand hygiene, relatively high compliance in insertion bundles and maintenance bundles. We created our own dashboard looking at our infection rates and central line bundles. We started doing spot checks and double checks to see what the compliance was, and showed a completely different story. Our insertion bundle compliance was actually only 71%, where the data which was being given to us was saying it was more than 90%, which was just a paper compliance. Maintenance bundle compliance was far below. So there was a problem. So we started making slow improvements. The first thing was the patient environment. We made sure every incubator had a gel holder. And one of the things our staff fed back is when medications come, including IV medication, they've just been left on top of the incubator. So we said each baby needed to have a clean tray for the medication to be placed so they're given and cleaned regularly. We changed the computer keyboards to sealed, cleanable keyboards, which had to be cleaned every shift. And hand hygiene was a central focus. As you all know, that's the most important intervention we can do to kind of prevent infection. So we had posters, education, banning on mobile phone use in clinical areas, road shows, free accessibility of gel everywhere, and data collection and feedback. And if there were breaches, one-to-one feedback were given on the spot. So with hand hygiene, so this was a PDSA cycle we went through. So we planned to collect data and we said we needed to validate. We started mystery shoppers and we realized there was discrepancy in the data and also the way data was collected. So we standardized the data collection form. Then we started with the education again, road shows, lessons of the week. We collected data again, and it was a continuous cycle. Central lines, we updated it. It was a pretty basic guideline. So we updated on exactly what we expect on the unit. Procedures including standardized fixation, insertion competency assessment for all doctors. These are doctors who are very competent in putting lines in, but what we were assessing was the aseptic technique. So we made sure everybody stuck to what we wanted them to do. The antiseptic solution, because of the nature of the swab we were using for the lower concentration, we said all babies should be cleaned with 2% chlorhexidine. I'll come back to that in a minute. And we updated the care bundle monitoring sheet to kind of make it fit for purpose. So this is some of the training we did with simulation, how we are supposed to drape, how we're supposed to fix, and the use of at least 3 swabs while cleaning and cleaning just before you insert, and so on and so forth. We also embarked on a small research project, which one of my fellows did. And when we looked at our data, the babies who developed eclampsia, an infection with the line, most of them happen once they cross a 2-week mark. And there is some study, I think it's the Adam Millstone study from the US, which said the same. So based on that, we said we'll change to a 2-week maximum duration of the lines. Either it comes out or we electively replace it. I know this is very controversial. A lot of people will push back on this, but we implemented it because we were desperate at that time. And we were reviewing lines daily and making sure it came up when it was not needed. The other thing we did, the way our unit is organized, our intensive care rooms are organized into 4 rooms with 8 babies officially, but we have up to 10 or sometimes even 12. We said each room, all the infusions will be changed at the same time on a particular day. So there's 1 line break at best in the 24 hours. If we needed anything more, we could do it. So these were like routine TPNs, infusions, and everything. And every eclampsia was reviewed in detail to see what went wrong and what we could have done better. So we went through multiple PDSA cycles. So the first one was standardization, kind of do a guideline, checklist, and training. And we presented the data back to our staff continuously. In the second PDSA cycle, we looked at the line duration. Again, we collected the local data, and we decided to go to 14 days. And the third one was about antiseptics when we introduced a 2% chlorhexidine. What we immediately realized, we were getting a lot of skin injuries in the extreme preterms. So we sourced a new product with 0.5%, which could be applied a bit better. And since then, we haven't had any more skin injuries. And by the end of the 4th cycle, all the practice is embedded. But from time to time, it slips, and we have to go back and retrain, reinforce, and re-educate. And over the course of the first year of implementing this, our infection rates are gradually coming down. A lot of our internal KPIs and external KPIs went to green. And our infection rates in 2014, where the late onset BSI had been around 6.4, dropped to 4.7 by the end of the first year. And it continued into the next many years. So this is what we achieved over the course of the last 6 years. Having had a starting point of 6.33 late onset bloodstream infections per year, we came down here. The last 2 years we stagnated a bit. We're slightly better this year, but one of the worries we have this year, gram negatives have gone up slightly. There were reasons behind it. We had some chronic babies with chronic bowel issues who were extremely preterm who were kind of contributing to this data, but our cons infection rates have continuously come down, except last year where we had a spike. So whatever we've done seemed to be working. And this was, again, correcting it for 1,000 admissions. So as I mentioned, in the Gulf region, a few years ago, the reported was around 56 per 1,000 admissions. When we first started, we were somewhere here, 160 and in the hundreds. Progressively, we've been able to bring it down to what our rest of our sister units are doing around the region. We're probably slightly below now, but still we've got a long way to go. My markers of the WARN data medians have disappeared from the slide. This is just comparing to what we are still outliers on WARN. We're not finished with this yet, and there's still work to be done, but we are still hopefully moving in the right direction. So in summary, what I wanted to say is bloodstream infections are preventable, regardless of which part of the world you work in, even with resource constraints and space constraints. Benchmarking both internal and external is important. Make sure it's fit for purpose for your unit. And a continuous quality improvement methodology is a powerful tool to monitor outcomes and build on success. And it's a journey. It never ends when it comes to things like this. We do have hiccups along the way. And we hope at some point with our new hospital potentially opening up in the next few years and proper planning of space, we might get to where we need to be. And that some of the team members have contributed very actively to this initiative. Of course, all the staff on the unit have worked quite hard, and I wish to thank all of them. And thank you to the organizers for letting me present this data. Thank you.
Thank you very much, Dr. Hafiz, for a very practical presentation. I'm sure you're going to have a lot of questions about this important topic for our neonatal care. We will have all questions at the end of this session. It's my pleasure and honor to introduce the next speaker of this session, staying in the theme of infection. I would like to present Dr. Dustin Flannery. And Dr. Dustin, attending neonatologist and newborn care at Pennsylvania Hospital in Philadelphia, USA. He's assistant professor in pediatrics and Perelman School of Medicine at University of Pennsylvania. He's a graduate of Philadelphia PCOM, sorry. And his research interests are neonatal infections, disease, and antimicrobial stewardship. Dr. Flannery has received research funding from CHOP, National Institute of Child Health and Human Development, an agency for healthcare research and quality, and Center of Disease Control and Prevention. In the morning, we have a presentation about the management of babies born to COVID mothers. Dr. Flannery will complement this presentation by discussing maternal and neonatal protection for COVID-19. The floor is yours, Dr. Flannery.
Hello, my name is Dustin Flannery, and I am a neonatologist and clinical researcher at the Children's Hospital of Philadelphia and University of Pennsylvania in Philadelphia, PA. Today, I'll be speaking about maternal and neonatal protection from COVID-19. Here are my disclosures. The objectives of this talk are to discuss how does COVID-19 affect pregnant patients and newborns? Should pregnant women get the COVID-19 vaccine? And lastly, how can newborns be protected from COVID-19? Let's start with how does COVID-19 affect pregnant people? But before we talk about how the virus affects pregnant people, it's important to understand how often are pregnant people even infected with COVID-19? I will discuss studies we performed on seroprevalence of the virus in our community. Seroprevalence studies are basically studies of antibodies in a population. Such studies are an important component of the public health response to COVID-19. Viral testing data, such as PCR, may underestimate mild or asymptomatic cases. And assuming all exposures result in an immune response, these studies may be a more complete reflection of community exposure. This immunity within a community can help us estimate overall community viral exposure. For these studies, we collected residual sera obtained for clinical purposes that was scheduled for discard after maternal birth hospital discharge. Sera samples were de-identified and transferred to our research laboratory, where they were tested by ELISA for SARS-CoV-2 IgG and IgM antibodies to the spike receptor binding domain antigen. We also collected limited clinical data from review of electronic medical records. During the early pandemic preliminary period, April through June 2020, we enrolled 1,293 women who delivered at 2 Penn hospitals and had available sera specimens. 80 or 6.2% of the delivering women had IgG and or IgM SARS-CoV-2 specific antibodies on admission. During the same period, there were 23,160 cases reported in the city of Philadelphia, which has a population of nearly 1.6 million people, suggesting an infection rate of 1.4%, which is more than 4 times lower than the estimates based on our serological data of women presenting for delivery during that period. We found striking and statistically significant race and ethnicity differences in seroprevalence rates during this preliminary period, with higher infection rates in Hispanic and Black women of about 10%, compared to 2% in white women and less than 1% in Asian women. We continued enrollment after this preliminary period, and in the study period to date, spanning from April 2020 through February 2021, we've enrolled almost 8,000 women presenting for delivery. Of these, 93% had available sera, and 845 women, or 11.5%, were seropositive, with detectable IgG and or IgM, as shown in the study flow diagram. The proportion of women who were seropositive almost doubled since the preliminary period. 56% had detectable IgG only, 5% had detectable IgM only, and about 39% had both detectable IgG and IgM. The characteristics of the study population are shown here, broken down by the total cohort and seropositive and seronegative groups. Women who were seropositive were younger and had higher rates of obese pre-pregnancy BMI when compared to women who were seronegative. There were no significant differences between the two groups in maternal diabetes, hypertensive disorders, mode of delivery, preterm delivery, or live-born infant status. The moving average of overall seroprevalence during the study period is shown here, as the black line and 95% confidence interval in gray shading. Time is on the x-axis, and percent seropositive is on the y-axis. There was a statistically significant increasing trend over time with a p-value for trend of less than 0.001. As you can see here, we were not able to account for difference between infection and vaccination status in this data. We found that the seropositivity rate remains higher among Hispanic Latina women and Black non-Hispanic women compared to white non-Hispanic women and Asian women. And while there is a statistically significant increasing trend over time for each group, the gap between different race and ethnicities remains. In conclusion, seroprevalence rates in special populations, such as pregnant women, can provide insight into the exposure in a community. Overall, 11.5% of parturient women delivering at 2 Philadelphia hospitals from April 2020 through February 2021 had evidence of SARS-CoV-2 antibodies, with more recent rates surpassing 30% and increasing trends in seroprevalence over time, which may be due to increasing infection or vaccination, or both. We found race ethnicity differences in SARS-CoV-2 exposure, identification of factors that contribute to these differences, including systemic racism, may inform public health measures aimed at preventing further infections. While our study assessed virus exposure among pregnant women in the community, other work has assessed whether or not pregnant women are at higher risk for severe COVID-19 disease. It is well known that during the 2009 H1N1 flu pandemic, pregnant women were generally at increased risk for severe disease, including disease leading to hospitalization, admission to an intensive care unit, or death, as compared with non-pregnant women and the general population. Pregnant women accounted for about 5% of deaths, despite accounting for only 1% of the population. So knowing that physiologic and immunologic changes during pregnancy increase the risk of infection severity from other respiratory viruses, namely influenza, there were legitimate concerns about the effect of COVID-19 on pregnant women early on. Now, a year and a half into the pandemic, we've started to analyze data from a number of sources. An analysis of 77 cohort studies published last September made clear that pregnant women are a high-risk group for COVID-19. The review included data from more than 11,000 women with confirmed or suspected COVID-19 and who were hospitalized during their pregnancy for any reason. The odds of a pregnant woman with COVID-19 diagnosis being admitted to the ICU were 62% higher than for non-pregnant women of reproductive age. And the odds of needing invasive ventilation were 88% higher. The risks of other morbidities, including maternal mortality, preterm birth, and NICU admission, also appear to be higher, although there are conflicting reports. A CDC study echoed these findings. The study included more than 400,000 women with a positive test and symptoms of COVID-19, of whom 23,000 were pregnant, and found similar increases in the odds of ICU admission and invasive ventilation in pregnant women. The CDC continues to track data to date on COVID-19 during pregnancy. And as of this week, October 11th, 2021, they have reported a total of over 128,000 cases in pregnant women and 180 maternal deaths. Internationally, the effects of the pandemic on maternal outcomes has been assessed, including in a recently published systematic review and meta-analysis in Lancet Global Health. And while the studies included thus far are likely a limited picture, a clear signal has emerged, particularly in low and middle income countries, where there's an increased odds of stillbirth and maternal death. I think it will be some time before we fully know how the pandemic impacted these and other important outcomes, and it's very likely that the impact may be different across various settings and regions. Let's switch gears now and discuss how COVID-19 affects newborn infants. Practical questions from newborn care providers emerged early on in the pandemic, such as, how should neonatal care providers protect themselves? Should new mothers with confirmed or suspected COVID-19 be separated from their newborns? Do newborns born to infected mothers require testing? Can infected mothers breastfeed? And how should infants with possible COVID-19 be cared for in the NICU setting? And what criteria should be used to discharge such infants to home? Although evidence was accumulating to inform adult care, relatively few data were available to guide neonatal care when mothers were infected. Yet, neonatal clinicians and obstetricians were faced with this on a nearly daily basis. The early recommendations from the American Academy of Pediatrics Committee on the Fetus and Newborn provided some guidance, such as precautions for birth attendants and staff attending a birth when the mother has COVID-19. Importantly, they did recommend against rooming in for mothers and well newborns. While difficult, temporary separation was thought to minimize the risk of postnatal infant infection from maternal respiratory secretions in a time where it was unclear how infected newborns would be affected. For breastfeeding, it was recommended that alternate caregivers feed expressed milk. Guidance was also issued for NICU care, including how and when to use certain PPE, isolation, cohorting, unit visitation, and discharge criteria. You may ask, why were the initial recommendations from the AAP so conservative? Isn't the AAP supposed to advocate to keep mothers and newborns together under all circumstances? And really, the reasoning behind these recommendations relate to the 2009 H1N1 influenza pandemic previously discussed. Although data were available before 2009 suggesting that pregnant women were at increased risk for influenza-associated complications, H1N1 provided solid data on this vulnerability. Pregnant women with the 2009 H1N1 influenza virus were at substantially higher risk for hospitalization than the general population. Moreover, the 2009 pandemic H1N1 virus was also bad for babies. Infants born to women who had been severely ill with influenza complications had increased risk for adverse outcomes, such as preterm birth or small for gestational age. And of most concern, infants less than 6 months old who experience influenza virus infection have the highest rates of hospitalization and death of all children. In light of all this, the National Registry for Surveillance and Epidemiology of Perinatal COVID-19 Infection was created. This was a collaboration led by Dr. Mark Hudak at the University of Florida, who at the time was the chair of the AAP section on neonatal perinatal medicine. He and some of our collaborators at CHOP and Penn created a REDCap-based survey to collect de-identified information on mothers and newborns at sites across the United States. Initially, the registry focused on women who were SARS-CoV-2 positive within 14 days of birth, though it now also collects information if the woman was positive at any time during pregnancy. This initiative was supported by the AAP infrastructure and received funding through a contract with the CDC. Here are the data from late May 2021, about 14 months into the pandemic. There are data from almost 10,000 dyads in the registry from almost 300 centers across the United States. Again, the majority of women were asymptomatic on admission, which could reflect true asymptomatic infection or persistent PCR positivity after resolved infection. The race ethnicity breakdown is shown here, with a Hispanic predominance. About half of the women had roomed in with their newborn, and the newborn test positive rate remained low at about 2%. The data are not shown here, but importantly, the positivity did not differ between infants separated or roomed in with the mother. So what have we learned so far? Well, the highest risk to the newborn is among mothers with onset of illness within a week of delivery. The lowest risk is among those with onset of illness more than 1 week before delivery. Why is this? Potentially because the women are no longer contagious, or possibly related to the role of protected antibody, which we'll talk about shortly. Many women were tested per obstetric admission protocols, universal testing, not due to symptoms or exposures, and were probably not contagious at the time of delivery. This is potentially because many had infection remote from delivery with persistent PCR positivity. There seems to be no difference in overall risk with separation versus rooming in, as long as infection prevention steps are taken, which was an extremely important observation. And so this was a really nice example of how evidence-based medicine is supposed to work. Real-time evidence was able to inform these important guidelines to allow neonatal providers to safely optimize care of mothers affected by COVID-19 and their newborns. In addition to tracking COVID-19 during pregnancy, the CDC also tracks positive testing for SARS-CoV-2 among infants born to pregnant women with COVID-19 in certain jurisdictions. Similar to the AAP findings, the rate of positivity among tested newborns suggests the incidence of newborn infection is quite low. Currently, such tracking cannot distinguish between vertical transmission before delivery and horizontal transmission of the disease during or after delivery. So in summary, for newborns, most do not become infected, and those who are usually don't get sick. However, some studies do suggest that the virus can cross the placenta, though this seems to be a rare phenomenon. Case reports continue to emerge of infants born with neurologic complications after maternal COVID-19 infection during pregnancy. And currently, it remains unknown how the virus can damage the placenta and cause indirect injury to the fetus and newborn. So we talked about how COVID-19 affects pregnant women and newborns, but now we'll discuss how can pregnant women be protected from COVID-19. Historically, pregnant women have been excluded from early vaccine trials. As this one editorial states, this is both unjust and imprudent from a public health perspective. Instead of protecting women from research, we should be protecting women with research. And with little to no data, the CDC early recommendations were understandably ambiguous. The CDC early on stated that getting vaccinated is a personal choice. Any of the currently authorized COVID-19 vaccines can be offered to people who are pregnant or breastfeeding. If you have questions about getting vaccinated, a conversation with your healthcare provider might help, but is not required. And so pregnant women early on were essentially left in the dark. The CDC did create a subset of their vSafe registry where participants who report pregnancy at the time of vaccination could be actively contacted to enroll in a pregnancy registry. As of last week, more than 163,000 vSafe participants have indicated they were pregnant at the time they received the COVID-19 vaccination, and more than 5,000 have been actively enrolled. The participants are contacted once per trimester, after delivery, and when the infant is 3 months old. Outcomes of interest include miscarriage, stillbirth, pregnancy complications, maternal ICU admission, and birth and neonatal outcomes. And importantly, these data are and will continue to be publicly available. So far, the preliminary data from the vSafe Pregnancy Registry, including about 8,000 women, which was recently published in the New England Journal, have been reassuring, finding no clear difference from background rates for pregnancy and neonatal outcomes. There are no red flags so far. Just last month, the CDC released a health advisory recommending urgent action to increase vaccination among people who are pregnant, recently pregnant, and those who are lactating, who are trying to become pregnant now or who might become pregnant in the future. This was a strong change in stance from the CDC, who now recommends that COVID-19 vaccination, either before or during pregnancy, strongly is suggested because the benefits of vaccination outweigh known or potential risks. The highest number of COVID-19 related deaths in pregnant people in a single month of the pandemic was reported in August 2021 in the United States, likely related to the highly infectious Delta variant. Despite the known risks of COVID-19, recently it's been reported that only 1/3 of pregnant people in the US are fully vaccinated. Finally, I will end with how can we protect newborns from COVID-19? We know that in general, newborn immunity derives from innate immune responses, maternally derived transplacentally acquired antibodies, and breast milk acquired immunity and protection. Most neonatal guidance around infectious diseases is centered on how maternally derived immunity protects the newborn. For instance, maternal infections at birth, such as varicella, and also ACOG recommendations for maternal influenza and Tdap vaccine during pregnancy to protect the newborn from influenza and pertussis before they're eligible for vaccination. Using this knowledge and the study framework I previously described, we scavenged maternal and cord blood sera after clinical use when scheduled for discard from April through August 2020. We collected clinical, serologic, and SARS-CoV-2 nasopharyngeal PCR testing data to determine factors associated with placental transfer of SARS-CoV-2 specific antibodies. Of almost 15,000 dyads, there were 83 women with antibodies, and 72 passed these antibodies on to their newborns. Of the 11 who did not pass on antibodies, most had very low levels of antibody and or had been recently infected, likely not allowing for enough time for antibody development and transfer. Here we assessed antibody levels and transfer by maternal severity of illness and found that there was similar antibody response and transfer to the newborn, whether the mother had symptomatic, mild, or moderate to critical disease. SARS-CoV-2 IgM antibodies were not detectable in any of the 72 seropositive infants. The figure on the right demonstrates that IgG concentrations in cord blood positively correlated with maternal IgG concentrations, which is not surprising. Among the 11 cases where there was a seropositive mother and a seronegative infant, 5 of the cases, the mother was only seropositive by IgM without IgG, and we know that IgM generally does not cross the placenta. In 6 other cases, the maternal geometric mean IgG levels were significantly lower compared to the 72 mothers with seropositive infants. And among mothers with well-dated onset of illness and nasopharyngeal PCR testing, cord IgG was present in all cases if the onset of illness was greater than 15 days before birth, which makes sense. The mother needed time to create her own antibodies and then initiate transfer to the newborn. The figure here on the left demonstrates that the transfer ratio of IgG antibodies from the mother to the infant was positively correlated with days from NP-PCR testing to delivery. So, our study showed that women who are infected during pregnancy can and usually do pass antibodies on to their newborn. But can maternal vaccine provide newborn protection? Here is the first case report, but certainly not the last, that was published suggesting that a newborn had antibodies to the virus, delivered 3 weeks after the maternal first dose of vaccine. At our centers, we have started to assess maternal antibody responses to vaccination in comparison with our prior work with women with a history of infection. Notably, these are raw antibody levels and not geometric means. But as you can see, our preliminary data here show that the antibody response to vaccine, both Pfizer and Moderna, is very robust in comparison to infection. Here the data are presented visually, and again, this suggests that the antibody response to vaccines is greater in comparison to both asymptomatic and symptomatic history of infection. As we would expect, antibody transfer from the mother to newborn is quite efficient. For women with infection or vaccination, as demonstrated by mean transfer ratios greater than 100% for all the groups. Here's the bottom line. Pregnant women with COVID-19 are at higher risk of hospitalization, severe disease, ICU admission, mechanical ventilation, and death. Newborns are infrequently infected with COVID-19. They can likely become infected in utero, although this seems rare, and it's more common to see infection of the newborn during or after delivery. Most newborns who are infected have mild illness, but severe illness does occur, and there are case reports across the globe of infants requiring ICU admission, mechanical ventilation, ECMO, and even infants who died. Pregnant women should discuss the risks and benefits of COVID-19 vaccine with their healthcare providers and understand more recent recommendations from the CDC that they should be vaccinated during or before pregnancy to prevent severe illness and to protect their newborn. So what changes might you make in your practice? 1, counsel mothers with COVID-19 infection that the risk of newborn infection is relatively low, around 2.5%, when infection prevention steps are taken. Inform pregnant women that COVID-19 antibodies from both natural infection and vaccination cross the placenta. And lastly, be aware of the differential impact of COVID-19 infection on pregnant patients. For more information on this subject, please see the following publications which were discussed during this presentation. I thank you so much for having me at this conference and for listening to the presentation of the results from our recent COVID-19 studies, and I now welcome any questions. In addition, I thank the conference organizers for having me, including my division chief, Dr. Eichenwald, and my research mentor, Dr. Karen Popolo, for their contributions to this presentation. Thank you.
Thank you very much, Dr. Dustin, for a very up-to-date presentation about COVID-19 in pregnancy. We're moving to the next presentation of this session, which will be a combined presentation by Dr. Natalie Reintel and Dr. Holly Hedrick. Dr. Natalie is attending neonatologist and co-director of the neonatal surgical team and medical director of the neonatal ECMO program at Children's Hospital, Philadelphia. Dr. Natalie has many interests in addition to the care of neonates, including congenital anomalies requiring neonatal surgery, also the babies who require heart and lung bypass ECMO. And she has a lot of experience in neonatal surgeries, including management of myelomeningocele, pulmonary hyperplasia, pulmonary hypertension, and congenital diaphragmatic hernia. She's an expert in perioperative care for surgical neonates. Dr. Natalie will be joined in her presentation by Dr. Holly Hedrick, who is the chair of pediatric surgery and attending pediatric fetal surgeon at Division of Pediatric General Thoracic and Fetal Surgery at Children's Hospital, Philadelphia. Dr. Holly is a surgeon in the Division of Pediatric Surgery and Thoracic Fetal Surgery, Children's Hospital, Philadelphia. She has really a great accomplishment of creating a specialized program offering most comprehensive, complete current care for specific need of patients who need management of their lung function. And she has a unique program right now of treating pulmonary hyperplasia program. It was founded in 2004 and really very impressive work of combining multidisciplinary team of neonatologists, cardiologists, pulmonologists, audiologists, gastroenterologists in providing comprehensive care for congenital diaphragmatic hernia patients. So the presentation will be about postnatal management of congenital diaphragmatic hernia. Please join me. Welcome Dr. Holly and Dr. Natalie.
So good afternoon. Thank you so much to Dr. Khan and the rest of the organizing committee for inviting Dr. Hedrick and I here today to speak with you on the postnatal management of congenital diaphragmatic hernia. We have nothing to disclose. So today we will do a quick overview of the pathophysiology of congenital diaphragmatic hernia, discuss some of the prenatal considerations that do affect the postnatal management, review a few details about the delivery room and neonatal management of these kids, and review how pulmonary hypertension and cardiac function are both critical in terms of caring for them and getting them through this critical time period, and really the importance of working as a team to accomplish this goal. We've long thought that babies with CDH have small lungs, lung hypoplasia. And with that, they also have a small pulmonary vascular tree. And the vessels are quite thick and the whole tree is quite pruned. But more recently, we've been turning our attention toward the heart and really looking at the size of the ventricles, in particular the left ventricle, and also the function and how this, all three pieces, this tripartite model, this pathophysiology within the thorax is so critical to their care.
So despite all the recent advances in neonatal care, attempts at prenatal interventions, attempts at, really intense multidisciplinary care, CDH remains the cause of the most non-cardiac neonatal in-hospital mortality. So this is from a recent publication in the Annals of Epidemiology. It is multiple countries, and it just shows that it's still a persistent problem despite all of our recent advances. In addition, it's costly This is a paper that's from Chicago, used the kids inpatient database, and the title of this was ECMO Foots the Bill. If your baby needs ECMO, it increases the cost by 2.5 times. And so it's a significant problem that persists. And yet we do think that there are ways that we can modify things to actually win at CDH. So one of the biggest challenges is that there's a huge spectrum of disease. So we know some babies who are postnatally diagnosed don't seem to even notice that they have a CDH, and these are children who do quite well. There is another subset of children who are with severe hypoplasia, severe inadequate gas exchange, who it seems like no matter what we do, we cannot win. They do not survive. So this is up to 30% of the population. And then there's this huge middle ground, which we know is where all the little details matter, and we can either push the baby into a more severe category or hopefully push them into a better prognosis. And so we're really focusing today on these first two groups, the middle ground where all the little details matter, and then the severe group where has been the most frustrating to date. So we know that with time in our own cohort, that CDH survival has improved over time. When Dr. Rentoul and I started as fellows, it was sort of a 50-50 endeavor. Now we're up to all comers, 86% survival rate in our institution. And this has really been borne out in multiple single center publications across the country, across the world. And we also know that that cohort that's doing better is actually that severe cohort. So the red line represents those with liver up, and we know that their survival has increased over time. And that really, we think, is part of our discussion today, has to do with our aggressive use of things in our toolbox that have to do with the heart, pulmonary hypertension, and some of the therapies that are now available. We also have been able to decrease our ECMO rates over time. And so we know ECMO is a huge exposure. We know ECMO is life-saving in certain circumstances, but we also know that once we go on it, we're committed to a whole nother set of potential complications. And so in our most recent cohort, the last 5 years, our left CDH ECMO rate is around 22%, and our right CDH ECMO rate is around 30%. And so we think this really has to do with really being able to manage the babies from those first moments. And so Dr. Rentoul is going to go into some of our strategies to help improve this. So what makes a difference? This is our care plan, our model of care at Children's Hospital Philadelphia. It starts usually with a prenatal diagnosis. The fetal treatment center was founded in 1995. And in 2008, we opened a special delivery unit, which really allows us to care for the babies from those first few minutes. We also developed a neonatal surgery team, which is, or service, which is co-management. So it includes neonatology, it includes surgery, it includes close input from the pulmonary hypertension team, cardiology, from pulmonary, especially in those babies that are going to be discharged on respiratory support, developmental care from the get-go, and nutritional support. And then it was a really nice introduction to point out our pulmonary hypoplasia program, which is our long-term follow-up program that includes babies with mechanical reasons for having small lungs. And so all those same specialists that met the baby in the NICU will see the baby for weeks, months, and years to come. And so we find this to be a responsibility to look for those meaningful long-term outcomes and to no matter what our innovative therapies are, to really prove that they're working in the long term. So this is our sort of overall view, and we're going to sort of narrow it down and go into the different parts in the subsequent parts of our talk. So really the first thing is, trying to nail the diagnosis even before the baby's born. And we know this makes a difference. The first level is the first fork in the road. We usually tell the parents is the baby syndromic, or is there a genetic difference? The second fork in the road is there a concomitant cardiac difference? And then finally, liver position and lung size. It seems like sometimes the conversation starts with number 3, but it really needs to start with number 1. So we know that up to 40% of babies with congenital diaphragmatic hernia have complex disease. So they have other anomalies or genetic differences. And so this is just a partial list of some of the things that we can find. There's ongoing work with Dr. Donahoe's group, with our own group, to try to figure out some of these other causes of CDH and why it happens. We know that it's complex. We also know that have a concomitant cardiac disease is huge. When I was first started in training, when we both started in training, this was thought to be a death sentence. But we know that with aggressive treatment, with the use of ECMO, with the use of some of our advanced medications, that we can get survivors in the CDH plus congenital heart group. Things that seem to matter are, is it a critical congenital heart difference? Is there a hypoplast? And how big are those lungs? Which will determine and dictate whether or not a full corrective cardiac therapy, cardiac intervention would happen. And so our overall survival, most recent ELSO database look was around 50% with those who had concomitant heart and congenital heart disease. So these are just two recent publications that will be listed at the end. And then finally, we get to liver position and lung size. We know that when the liver's up, the survival is nearly 100%, is greatly affected. So when the liver is down, survival is nearly 100%. When liver's up, in early publications, this seemed to decrease that survival to half. We know that now it's more like 80%, but it's still a significant difference. And so this is the first thing that we look for. Then we look at how big are those lungs. And so in the 90s, the term LHR, or lung to head ratio, was developed. This looks at the contralateral lung at the level of the four-chamber heart, and then it divides by the head circumference. What we know is that traditionally or historically, less than 1 was considered severe. We also know that this increases over time, and so Dr. Depress' group developed the observed over expected LHR. And so this is really what we use today. And so an observed over expected LHR of less than 25% is considered severe. We also know that we can look at lung volumes, and we can look at both sides by MRI. And so an observed over expect total lung volume of less than 25% is also considered severe. These images just depict the ultrasound images and the way that measurement is made. And the other image is actually an MRI showing the liver going up, the stomach in the back, and bowel loops. So are there prenatal interventions that can help make these outcomes better? So in the world of fetal surgery, this is one of the first problems because it is severe that was attacked. The group in UCSF did anatomical repairs, and those that were the most severe, those that had the liver up, this was the group that actually had no survival when done on open fetal surgery. Subsequently, a physiologic approach was attempted. This is ligating the trachea. When you ligate the trachea, lung fluid builds up. This causes stretch, and this causes proliferation of the lung. The first studies were done with an open hysterotomy, application of a clip, and then removal of that clip at an exit procedure. And this was promising in that those that were expected to have a 0% survival actually had 33% survival, but they were plagued by prematurity, they were plagued by multi-system organ dysfunction. And so this was largely abandoned. Concomitant to this, Dr. Jan Depress in Belgium was developing the completely minimally invasive technique, the balloon, the single trocar entrance fetoscopic approach. And so this is really what's taken over, fetoscopic interluminal tracheal occlusion. The total trials began in 2008, and the very exciting publication of those this past summer revealed that it did look like for the severe arm, there was benefit. So the total trial had 2 arms. The severe group was those with an observed over expected of less than 25%. The moderate group was observed over expected LHR between 25 and 35%. The balloons were placed, you can see here, between either 27 and 30 weeks or 30 and 32 weeks, depending on which arm. And then in both arms, the balloon was removed at 34 weeks. And then postnatal care was standardized. This is just a summary slide from the New England Journal of Medicine showing that in the severe arm, there did appear to be a survival benefit. Those that managed expectantly had a 15% survival, whereas those that received the fetal intervention had a 40% survival. And this was stopped early for efficacy. This survival was lasting, so 6 months was no different than survival to NICU discharge. But there were associated risks, those being premature rupture of membranes. So for the expected arm, it was only 11% versus 47% in the fetal arm. Preterm labor concomitantly was very low in the expectant arm, but in the fetal arm was 75%. And so that is the trade-off. The moderate arms showed no survival or morbidity benefit in the initial study or the initial evaluation or analysis. So we are part of a pilot group through the North American Fetal Therapy Network. There are several centers that are doing this in the United States. We have completed 10. We had no maternal or fetal demise. We did have prolonged hospitalization in several of the pregnancies due to premature rupture of membranes. We had balloon removal, which was a combination of ways. 6 of the 10 were at fetoscopy, so planned. 2 were at exit, which means we had an emergent delivery, and 2 were at emergent C-section. So, 40% needed to have out of the expected 34-week balloon removal. They were born early at a mean of 35 weeks. The earliest was 33 6/7, and the latest was 39 weeks versus 39 weeks in our expectant arm. The ECMO rate, however, was lower. It was 3 out of 10, whereas in our expectant arm at the same time, it was 67%. We did have 1 infant death in the fetal arm due to multi-system organ failure, lymphatic obstruction at 90 days after surviving an ECMO repair. So that was very disappointing. Our 6 and 12-month follow-up visits have been completed in 6 of the infants, and we actually have had even longer term in a few of them. So, the bottom line for us was that the survivals actually appeared similar. It was 83% versus 90%, but we had a lower rate of ECMO, 30% versus 67%. We had a lower rate of needing pulmonary hypertension meds at discharge, 0% versus 60%. We had less respiratory support at discharge, and we had, importantly, a decreased length of stay, mean of 137 days versus 235 days.
So whether a baby has feto or not, our role as neonatologists really starts in the delivery room. We meet them, we intubate them immediately. We start with an FiO2 around 50%, aiming to have a goal preductal saturation of greater than 85%. People talk about gentle ventilation. It's really small breaths, rapid rate, tolerating some hypercarbia, but doing so, paying attention to the pH, really keeping it greater than 7.2 for the heart. It's a very typical baby, right? A scaphoid abdomen. There's a lot of organs up in the chest. Typical film, severe mediastinal shift. You can barely see any lung volume. So when we talk about optimizing their functional residual capacity, sometimes it's hard. You're just looking at that one little triangle in the right lower quadrant, but you really want to make sure you can hear some breath sounds on that side. Typically, when we look up at the monitor, we see this as well. So we have a preductal saturation and a postductal saturation probe on, and there's very frequently, we say, a ductal split, a desaturated number in the lower extremities. And, this is very typical, right? They're obligate shunters. We know how their pulmonary vascular tree is put together. They have to be, they're obligate shunters. So this is what we start to manage as we're getting to know them and getting to meet them, and then all the while trying to optimize them. So the most important thing is to make sure that whatever settings you're on, whether it's conventional or high frequency, and we put some typical settings here on the side, whatever settings you're on, you're really aiming to find that sweet spot. You don't want to have the patient underinflated or overinflated, because at those extremes, your pulmonary vascular resistance increases. In addition, we know that if they're acidotic, the pH drops, or they're hypoxic, that can also worsen the pulmonary vascular resistance. So paying attention to all of those details is incredibly important. And we do treat the left diaphragms very similar to the rights. We know, again, that pulmonary vascular tree is very thick. But the heart, that's really where we've really, I mentioned that before, turned our focus. What is the size of the left ventricle, and how is it functioning? And so on the first echo, And we do obtain that, within the first 24 hours, sooner if there's a base deficit or some hypotension. But what we're really looking for is not only the ductal shunt to look at the PDA, but also at the atrial shunt. And very importantly is to look at ventricular function, the left and the right. And this is what we use now to treat them. And this is our approach. So we know that they're shunters. How severe is that pulmonary hypertension? And then taking into account their echo findings. If it's a patient that has predominantly left ventricular dysfunction, starting some low-dose epinephrine, low-dose dopamine, just to support that left ventricle. If this, and for patients who have persistent severe LV dysfunction, unresponsive to this, these are often the kids that wind up going on ECMO. But if it's mild to moderate and they start to improve, in some of these kids still with significant shunting, we will do cautious use of inhaled nitric oxide. Now, if the left ventricle is sick and dysfunctional, they can develop pulmonary edema, so you really have to watch them closely. For kids with primarily RV dysfunction, but the LV looks good, we will start some low-dose dopamine and prostaglandin to keep the ductus open. And in these kids, we will do a nitric oxide trial and then follow for a response. Just a few words on nitric oxide, because it does sort of get a bad review in the literature. A lot of meta-analysis that weren't really designed to look at CDH kids, but said that it was not indicated and in fact led to worse outcomes. But we did a review of kids, a 5-year review relatively recently, and we found that 40% of our patients were responders. And when we looked more closely at the non-responders, they were more likely to have left ventricular dysfunction. And then the responders were less likely to require ECMO. So we do believe that it's worth a try in the kids who have severe RV dysfunction and high pH. And this is in keeping with guidelines from the American Heart Association and the American Thoracic Society, and also the Canadian CDH Collaborative. Inhaled nitric oxide is indicated for confirmed suprasystemic PA pressure without LV dysfunction, provided lung recruitment is adequate. Just mention one other medication that we've started to use more frequently, and this was a publication on our early experience showing that treprostinil, a very potent vasodilator, pulmonary vasodilator, can be used not so much in the acute phase. Like we always say, when you're first meeting them, nitric is the way to go, but it takes a few days to get up on this infusion as well. But we did see the BNP, that brain natriuretic peptide, start to diminish, and the pulmonary hypertension severity by echo also start to improve. So we're working now on another review of over 50 patients that we've used this on, and we've really seen a very nice response. And there are other medications that can be used. These are two that come to mind, and we thought we would mention in this talk with you, but there are a lot of other medications, sildenafil, bosentan, that can be used, but in conjunction with a cardiology team that specializes in pulmonary hypertension. I mean, that's really, back again to the team work. It really does. Everybody gets a piece of the baby, and they specialize in that, and then we work as a team to try to optimize them. This publication is quite interesting too, really focusing on the ventricular dysfunction. So you can see here in kids who have CDH but no cardiac dysfunction, 80% survival. And then as soon as you start to see right ventricular dysfunction, left ventricular, and then combined, their survival curves start to erode. And the survival curve for the right ventricular and left ventricular dysfunction combined is the worst. And these are often the kids that aren't responding to all of our management, and they're the ones that typically are the kids that end up going on ECMO.
So at our institution, we typically use VA ECMO. This is just a view of a neck with an arterial cannula in and a venous cannula in. And that's really for optimally unloading the right side of the heart. As we said before, it used to be sort of a 50-50 endeavor, and now it's about a third of our patients. The one thing that we really pay attention to now is that LV dysfunction potential. And so once we have severe ventricular dysfunction, in most cases, the only way we're going to be able to win is through ECMO. Most of our patients, once they go on ECMO, are on ECMO about 2 weeks. Ideally, if they go on ECMO, we would try to get them off ECMO before they are repaired, but that is really an area of great controversy. So in terms of surgical repair of CDH, timing, ideally, this is when the pulmonary hypertension is resolved, when those right-sided pressures are no longer suprasystemic or even systemic. But this isn't always achievable in the near term. And so really the question of when they're going to be repaired when they're off ECMO is we just keep following the echoes and we'll keep waiting. If they're all, and we'll start adding medications as needed in conjunction with our pulmonary hypertension physicians. If they're on ECMO, it really depends on how they behave before they went on ECMO. So in those patients that never ventilated well, that had very, very poor gas exchange, and they were never able to do much on their own, those are the patients that are going to have an early repair on ECMO. But some patients actually have quite good ventilation, and it's just severe pulmonary hypertension and cardiac dysfunction. For those, we wait for the cardiac dysfunction to resolve, and then we'll take them off ECMO. And this is achievable in about half of our patients once they go on ECMO. Location. So we actually take the OR to the baby. And so we love our NICU, we love our neonatologists, we love them watching over our patients. We've just gotten to a good place. We don't like to transport them. We don't like someone else managing their ventilation. And so anesthesia comes to the NICU. We stay in the NICU, and the neonatologist actually stays during the case, and it's a really collaborative effort. And so anesthesia, neonatology, surgery, pulmonary hypertension team will sometimes pop their head down too. So it really is we feel a game changer. Ideally, a primary repair is the most straightforward, and it's the best babies, but sometimes we need to use a patch in up to 70% of the cases. We have started moving towards a muscle flap, which is native material. We don't have to worry as much about patch infection. We don't have to worry as much about recurrences. And so those are the long-term complications that we'll have to follow for. It is a long and winding road, and that's why we feel it's particularly important to delineate those meaningful long-term outcomes. And so we've been talking a lot about innovative therapies. We've talked about FETO. We've talked about advanced pulmonary hypertensive medications. But it's really important that we know what the outcomes of these patients are long-term, their functional outcomes. And so we've developed a long-term follow-up program that includes neonatal follow-up, psychology, developmental pediatricians, pulmonary medicine, cardiology, general surgery, nutrition, audiology, sometimes ophthalmology, sometimes orthopedics, to really be able to gather those meaningful long-term outcomes. This is a recent look at the 8 to 13-year-olds, so school-age children, and just showing that the majority of those are typically developing. The red bar graph represents their IQ scores, and you can see it looks like a normal distribution. At the 5-year mark for our CDH babies, what we can say is over 50% are typically developing. About 30% will still need some sort of therapy, occupational, physical, or speech therapy. And then a much smaller percentage, around 15%, have severe developmental issues that might require special schooling. And these tend to be the babies that had the severest neonatal course. So we're wrapping up, and I think if we had our take-home message would be really threefold. It would be preparation. If you can figure out what the disease is before they're born, it really helps you. It helps to be ready, and it helps to have a team in place. Attention to the heart would be our second point. It really is a three-pronged stool. It's not just the lungs, it's not just the pulmonary hypertension, it's actually the heart itself. Third would be those meaningful long-term outcomes that will take you back and inform your decisions in the future. I think if we said one thing over and over again, it's really that teamwork makes the dream work. I mean, it's a little cliche, but we have all these overlapping teams, and we know that the different perspectives truly make their care better. And so we really appreciate the opportunity to share our experience with you all today, and we're happy to take any questions. I know Dr. Rintoul, probably have something to say.
No, thanks so
Wrap it
much.
up.
I mean, I think we had one more slide. I mean, these are our email addresses. If there's any questions, even after the conference, if anybody wants to reach out to us, we're always happy to talk about CDH. It's a huge piece of what we do, and we really enjoy it. Anyways, thank you so much for the opportunity to speak with you today.
Thank you very much, both Dr. Natalie and Dr. Holly, for a really great presentation. Now we really go into the home stretch of the conference, an epic of the conference. We left the most important presentation to the end, and it's a pleasure and honor to welcome a dear colleague and a frequent visitor here to us in our conference from CHOP, Dr. Eric Eichenwald. Dr. Eric is known to many of us here in our region. He's a professor of pediatrics at Perelman School of Medicine, University of Pennsylvania, and he's chief of division of neonatology at Children's Hospital, Philadelphia. Dr. Eric graduated from Harvard Medical School. He receives training at Boston Children, and he is currently an alternative principal investigator in University of Pennsylvania, NIH, Neonatal Research Network, and co-principal investigator in a grant entitled Intermittent Hypoxia and Caffeine in Infants Born Preterm, ICAF study. Dr. Eichenwald, he is a member of Society of Pediatric Research, American Pediatric Society, and chair of subboard for Perinatal Medicine, American Board of Pediatrics. Also, he's the chair of AAP Committee of Fetus of Newborn, and associate editor in Archives of Pediatric and Children Fetal Neonatal Edition. I had to read the title a few times to get the topic at hand, but I like the mysterious topics. So the topic is therapeutic drift in ICU. When should we stop caffeine and cardiorespiratory monitoring or therapeutic hypothermia for mild HIE? Has the time come? Please join me. Welcome, Dr. Eric Eichenwald.
So good afternoon, everybody. Would first like to thank Dr. Junaid and Dr. Ayman for inviting me and my colleagues at the Children's Hospital of Philadelphia to speak at this wonderfully informative and cutting-edge conference. As Dr. Ayman mentioned, that this is my 4th year speaking at this conference, and I really am hoping that the next time we and my colleagues from CHOP are speaking here, that we'll be able to see our good friends in the UAE once again in person. Now, I did offer 2 potential talks for this conference, but I'm only going to talk about one of them, which is issues around caffeine therapy and monitoring for apnea, particularly through the end of the hospitalizations. And we're going to have some special emphasis on discharge issues. So my disclosures are shown on this slide. As Dr. Ayman mentioned, I'm currently on 2 research grants funded through the NIH, which are relevant to my topic today. And I do have one disclosure in that I will be discussing unapproved use of caffeine in premature infants during my talk this afternoon. So methylxanthines such as aminophylline and caffeine have been used in NICUs to treat apnea of prematurity for decades. Dr. Barbara Schmidt's landmark Caffeine and Apnea of Prematurity, or CAP trial, as she outlined brilliantly on Thursday morning at this conference, was conducted as a pragmatic international placebo-controlled trial of caffeine administered in the first 10 days after birth in preterm babies less than 1,250 grams birth weight. The primary outcome, as Dr. Barbara outlined, was neurodevelopmental impairment at 18 to 22 months to primarily address the safety of caffeine in this population. This trial definitively established that caffeine at the doses used was safe in preterm infants. As you know, and has been reviewed also at this conference, the other important and somewhat unexpected findings in this trial was a significant reduction in the incidence of bronchopulmonary dysplasia, or BPD, and improved neurodevelopment in the caffeine-treated infants. The reasons for these benefits remain unclear, but could be a direct pharmacologic effect of caffeine on the lungs and brain, or secondary effect through caffeine's primary pharmacologic effect in reducing apnea and subsequent hypoxic episodes, which could be injurious to the developing brain. Now, caffeine is now one of the most widely prescribed drugs in the extremely low birth weight population, really only second to antibiotics. And unlike almost all other drug exposures, its duration of use is measured in weeks. But in usual practice, stopping caffeine and monitoring for resurgent apnea events for several days is a typical discharge criteria in most NICUs. After publication of the CAP trial, there have been several drifts in practice in the use of caffeine in the NICU that are not consistent with what was studied in that trial. Much of these were reviewed by Dr. Eduardo Boncalari in his talk on Friday. As Dr. Boncalari gave us the information on, multiple observational studies concluded that early caffeine use, usually described as starting at less than 3 days of age, was associated with the reduction in BPD, as well as improved neurodevelopment, whereas later start times were not. This observation led many NICUs to prescribe caffeine in nearly all ELBW babies on the day of birth, both as a prophylactic treatment in the hope to prevent BPD, but also in some centers as a quote unquote neuroprotective drug. In addition, several published international guidelines also suggest that doses of caffeine much higher than those studied in the CAP trial be used for more severe apnea. So we know that doses as high as 40 milligrams per kilogram loading and 20 milligrams per kilogram maintenance dosing are used routinely in some United States NICUs. Now, I believe there are several potential safety concerns of these practices, in that the mean gestational age of infants included in the CAP trial was 27 weeks, and infants at borderline viability, who are most likely to require prolonged mechanical ventilation and perhaps might be at most risk for adverse drug effects, were underrepresented in the trial. So it is not clear whether the same benefits and safety profile extend to the youngest gestational ages. In addition, while there is some efficacy data of higher doses of caffeine than were used in the CAP trial, there is complete lack of safety data at these higher doses, which can potentially be pro-inflammatory. And finally, and even more poorly studied, I will talk about a bit later, some sites have elected to use caffeine at discharge for home therapy as well. Despite widespread use of caffeine, there has been much attention in recent years to the phenomenon of intermittent hypoxemia, or IH, which is the focus of my research currently. It is defined as periodic episodes of hypoxemia with a return to baseline oxygen saturations, which may be prolonged or very brief in duration. The diagnosis of IH is dependent on the use of continuous pulse oximetry, which is almost ubiquitous in most NICUs. However, NICUs use a variety of averaging times in their oximeters, which can affect the detection of IH, where long averaging times will only detect prolonged hypoxemia events, but reduce the incidence of alarms, whereas shorter averaging times can detect very brief episodes of IH, which are currently of uncertain clinical significance. We do know from a number of studies that IH is very common in extremely preterm infants, but it is more frequent at older postnatal ages, with a peak incidence at 4 to 6 weeks, when periodic breathing is most common. It is also more commonly seen in infants with evolving bronchopulmonary dysplasia and those maintained at lower oxygen saturation targets, which currently are likely not being used in most units. So this graph shows the distribution of IH by postnatal age in infants born at less than 28 weeks gestation. And you can see that there are many, many hypoxemic events per week in the hundreds, which peak at about 4 to 6 weeks of age and only slowly decline thereafter. As I will show you a bit later, these events also persist in many, if not most, convalescent preterm infants at the time of discharge home. So we know that these IH events are common, but is there any evidence that they are harmful? There have been several observational studies which have tried to address this issue. Here, I am showing one study from Dr. Richard Martin's group in Cleveland, Ohio, which showed an association of a greater frequency of IH with severity of retinopathy or prematurity, with babies who required laser therapy for their ROP, showing a higher number of IH episodes per week. Another study from Dr. Christian Poets analyzed data from the Canadian oxygen saturation targeting trial, in which babies less than 28 weeks gestation at birth had continuous pulse oximetry recorded until 36 weeks postmenstrual age. Dr. Christian found that when subjects were divided into deciles of time spent with oxygen saturations less than 80%, those with the highest amount of time with lower saturations compared to those with the least had a significantly higher risk of death or severe disability. Of course, these studies show an association, not direct causation of IH with poor outcomes. But as this model shows, suggested by Dr. Richard Martin's group, one possible hypothesis is that frequent, severe, or prolonged episodes of intermittent hypoxemia through several different mechanisms, including an increase in the inflammatory response, neurotransmitter imbalance caused by episodes of hypoxemia and reoxygenation, and production of reactive oxygen species induced by these repetitive hypoxemic and reoxygenation events may directly result in the development of poor outcomes through brain injury. These more severe and prolonged events, which tend to occur in the NICU earlier in the hospital stay, may need to be treated aggressively to prevent injury.
Well, that
However, there may be milder and therefore lower risk IH events, which may or may not have implications for outcomes and may not need to be treated.
This is the one with my heart.
So studies have informed us if and when to use caffeine in the premature baby, but when should we stop it? This aspect of caffeine use has been poorly studied and really is truly based on practice and expert opinion. In the CAP trial, which was pragmatic in design and left the decision when to stop the study drug up to the clinical team, the median age when the drug was stopped was just over 34 weeks postmenstrual age. A recent clinical report from the AAP Committee on Fetus and Newborn recommended stopping caffeine if the baby was event-free for 5 to 7 days off positive pressure ventilation, or at 33 to 34 weeks postmenstrual age. Now, I was the primary author of this guideline, and I can tell you that this recommendation was really based on no data, but was designed to prevent delays in discharge and to be sure that caffeine had been cleared while awaiting an apnea-free period prior to discharge. The goal of the committee's statement was to recommend that caffeine be stopped so that there was no delay in discharge home. So this graph shows the pharmacological and clinical data around what happens when caffeine is stopped. In the upper right panel, you can see how long it takes to clear caffeine from the serum with persistence of a therapeutic level for many, many days. Really, this doesn't start to decrease until about 5 to 6 days after discontinuation. This long half-life is one of its advantages as a therapeutic drug and why we were able to administer it once per day. But it is important to recognize in the development of a policy for an apnea countdown and transition to home. And in the lower left panel, you can see that as caffeine levels fall, there are breakthrough apneic events, reinforcing the need to monitor for a period of time if you stop caffeine prior to discharge home. Now, as in most practices, when there is not an abundance of evidence, but an overabundance of expert opinion, there is a lot of variation across NICUs as to what postmenstrual age when caffeine is discontinued. This one study of over 81,000 infants, less than 1,500 grams birth weight, who were treated with caffeine in several hundred NICUs across the United States, showed that there was significant variation, as you might expect, with the median postmenstrual age at stopping caffeine ranging from 32 to 37 weeks postmenstrual age. However, as I alluded to earlier, we also know that intermittent hypoxemia persists even in the convalescent preterm infant and probably worsens after stopping caffeine. This tracing shows recorded high-resolution oximetry with a very short averaging time in a preterm infant after stopping caffeine. You can see on the left, at 36 weeks postmenstrual age, while the baby is still hospitalized, the baby has multiple clustered episodes of oxygen desaturation, which improve but persist as late as 38 weeks postmenstrual age in a recording made at home after the baby was discharged from the hospital, seen in the right panel. This pattern of brief but clustered episodes of IH are very common, particularly in very preterm infants who have had a history of apnea or prematurity or have bronchopulmonary dysplasia. IH is also common in late preterm infants. As seen in this figure from a very recent study in babies delivered at 34 to 36 weeks gestational age, on the panels on the left, you can see that these late preterm infants had relatively frequent events of desaturations of at least 10%, which increase over the first 2 weeks after birth, probably because of an increase in periodic breathing, and then decrease thereafter. Now, this study also included a term control group, and interestingly, term babies also had intermittent hypoxemia in the first 2 weeks after birth, but these events were not as frequent or severe as in the late preterm infants. Now, these data perhaps are not surprising, since respiratory control is not an on-off switch, and unstable control mechanisms may still be in place even after 34 to 35 weeks in many babies. So what can, and more importantly, should be done about this persistent IH in preterm infants? Evidence suggests that persistent IH can indeed be treated. In this study by Dr. Larry Ryan and Carl Hunt, they randomized babies who were born at less than 32 weeks gestational age, who had been treated with caffeine for apnea, to extended caffeine citrate at 6 milligrams per kilogram per day, or usual care, meaning no caffeine, once the decision to stop clinical treatment with caffeine was made. They recorded pulse oximetry both in the hospital and at home. As shown in the graph, there was a reduction in episodes of IH at both 35 and 36 weeks postmenstrual age, But after 36 weeks, this beneficial effect of caffeine in limiting IH was no longer seen. Since it's known that caffeine metabolism increases after 36 weeks, these same investigators conducted a follow-up trial using higher doses at 14 and 20 milligrams per kilogram per day of caffeine citrate. With these higher doses, you can see in the graph that they were able to show a continued decrease in the incidence of IH up to 38 weeks post-menstrual age, seen in the red squares. So what should we make of these data? It has been suggested by several investigators that we as neonatologists should be concerned about the potential harmful effects of persistent IH in preterm infants, and perhaps extend caffeine therapy after discharge. It does work to prevent these episodes of IH, but it is not yet clear whether these are harmful. It is possible that simply not stopping caffeine could shorten length of hospital stay by eliminating the need for an apnea countdown as caffeine levels fall. I think there are at least two other unanswered questions about this practice. First, does it actually decrease length of stay as hypothesized? And if discharged home on caffeine, do babies need to also be sent home on a monitor in case doses of caffeine are missed or there is breakthrough apnea? In addition, since we have some data that extended caffeine can reduce the incidence and severity of intermittent hypoxia, is that a sole reason to extend caffeine to the home environment? It's not at all clear, as I mentioned, whether the IH we've seen in convalescent preterm infants is clinically important. And there is no evidence currently that a reduction in IH will improve neurodevelopmental or other outcomes. And finally, I think we run the risk of medicalizing what is a normal maturational phenomenon, which may not have any clinical significance to the individual baby. So somewhat sadly, that leaves us with the typical Cochrane Review conclusion that quote unquote more research is needed. Fortunately, there are at least 2 ongoing trials that I am aware of that are attempting to answer some of these questions. The first is known as the MOCA trial, or the Moderately Preterm with Caffeine at Home for Apnea trial, which is sponsored by the United States Neonatal Research Network with Wally Carlo as PI, and I am serving as a co-investigator. This study is a randomized placebo-controlled trial of extended caffeine in moderately preterm infants that specifically addresses whether use of caffeine up to and after discharge reduces hospital length of stay. So babies will be born between 29 and 33 weeks gestational age, are randomized to receive caffeine or placebo, and then will receive it for 28 days post-discharge, again with the primary outcome being length of stay. The second study, which Dr. Carl Hunt and myself are co-PIs, is a randomized placebo-controlled trial of extended caffeine in babies less than 32 weeks gestational age. This study has a primary outcome of reduction of the extent of IH exposure in caffeine versus placebo groups and includes recorded study high-resolution pulse oximetry in the hospital and at home. But it also has secondary outcomes of measurement of inflammatory cytokines, as well as a baseline and end of study MRI of the brain to explore whether decreasing the incidence of intermittent hypoxemia results in a less inflammatory bioprofile or less changes in the MRI of the brain. So while we await the results of these studies, I'll conclude with a few concrete recommendations for how to move the field forward, opinions that I think are indeed evidence-based. First, I think it is essential that all NICUs develop a common consensus on a rigorous definition of what is considered to be a clinically significant cardiorespiratory event, to improve provider consistency. This can be done as a quality improvement project, which I'll show on the next couple of slides. Second, I think it's important to develop strict documentation guidelines for staff to improve provider communication for better clinical decision-making. Lastly, there should be a consensus from clinicians for what the duration of the apnea countdown should be and what events should count as clinically significant and delay in discharge decisions. My opinion is that until there is more evidence gained from the trials that I've outlined, routine use of home caffeine therapy should be used only sparsely, perhaps in infants who are otherwise ready for discharge, who have failed 2 or more apnea countdowns, and those apnea events do not require significant intervention. So as I've mentioned about a quality improvement project, what I've shown on this slide is a QI project that was done by my colleagues at the Hospital of University of Pennsylvania. They defined a clinically significant event as shown with a heart rate and saturation definitions and asked staff to only document events which match these definitions and specified when babies should have their caffeine discontinued at around 34 weeks post-menstrual age, consistent with the Committee of Fetus and Newborn recommendation, and recommended that infants should be off caffeine for at least 10 days prior to discharge. And they also recommended that all babies should have not be discharged until at least 5 days of the last recorded clinically significant event. So this was written into policy, taught to the nursing staff, and built into the electronic record so there could be greater consistency in the management of apnea. Now, I've shown on this slide the progress of this QI project, which was recently published in Pediatrics, with the top panel showing a more consistent approach to the duration of the apnea countdown, narrowing to more closely to the recommended 5 days. And the bottom panel showing a decrease in the standard deviation amongst clinicians in the duration of that apnea countdown. There was also improved nursing documentation, as well as nursing satisfaction with the discharge process. And this is just one of several published examples of apnea and caffeine management and progress towards quality improvement projects at the end of the hospital stay. So I will close with this one last recent study from the Vermont-Oxford Network. They found a steady increase in the length of hospital stay and discharge weight from 2005 to 2018. Now, the reasons for this increase remain speculative, but in the paper, they speculated this may be towards different apnea management styles. But it is clear that how we make discharge decisions for preterm infants has many clinical as well as family and cost implications. So I thank you for your attention, and I do hope, as difficult as these virtual talks are, that it held your interest. And I know that Dr. Amen will be hosting a Q&A session for all the speakers immediately after this talk. So thank you very much, and I hope to see you all in the UAE next year.
Thank you very much for all the speakers for great presentations. I would like to welcome everybody to the final session for question and answer. And I'm sure all this great presentation is going to generate a lot of questions. I would like to ask also Dr. Junaid to join us. So we will start with the question to Dr. Hafiz. A really great project for quality improvement in decreasing the infections in an ICU. You present the outcome of your quality improvement in terms of number of infections per 1,000 admission. Since you did a lot of work on improving the compliance with a infection control for inserting the central lines, would that be better if you add the infection per 1,000 central line days instead of 1,000 admission?
We look at both. We have that data separately when we look at CLABSIs. And that has come down as well. I didn't present that data, that is available, but our CLABSIs are far and few in between, thankfully now. We've been going up to 6 months without a CLABSI at a time, though we've had a few in the last few months because of the particular population of babies we had. But that's come down as well. We look at that regularly, yes.
Okay. Thank you. We can alternate questions to all speakers, so we can. We have a lot of questions to Dr. Dustin about the COVID-19. One question is that when in your data, did you find that maternal infection with COVID-19 during pregnancy cause more premature labor or premature death, premature birth?
That's a great question. We did not specifically look for that in our local studies, although there was another group in the Penn CHOP system who did analyze that using a pre and post-pandemic cohorts, and they did not find a difference. Other studies have found a difference in either preterm birth or stillbirth. I think it's going to be some time before we really understand that, and I think there's probably going to be a difference based on the region or the cohort studied.
Okay, great. Thank you. For Dr. Holly and Dr. Natalie, it's great to know about the fetal surgery. Unfortunately, fetal surgery is not really a standard or available in many places. So my question to you about fetal surgery in severe congenital diaphragmatic hernia, if we would refer the patient to you in utero, what's the optimal gestation age that we're going to send to you? And what's the criteria to define that this is a severe or incompatible with life to do a fetal surgery? Do we look at the head or lung to head ratio? Do we look at liver presence in the chest or MRI finding? What's the criteria to refer?
The criteria is really the observed over expected LHR by the trace method. But that's can be a user dependent, that can be a hard, thing to always get the same number to get it right. So multiple measurements, and then looking at all the sort of surrogates that go along with that. So where's the liver? Are there any other congenital anomalies? So absence of other congenital anomalies, the liver up, and then the observed over expected less than 25%. It's also, if you're looking at the MRI, do you see any lung at all on the left? Is there severe mediastinal shift? Like if you're not sure of your measurement, those are some of the surrogates you could use. So those are really the criteria.
What's the gestational age that we?
So you would want to get the patient. You would want to get the patient to the center that can do this before 27 weeks. So and we found that we really feel good if we can see it be low multiple times. Like for us, it's not just, one low measurement, let's go, because you'd hate to commit them to that whole line. So really, we love it if we can see them multiple times. And it's our center does it in Europe. It's Dr. Deprest. He is really the master of the universe in terms of this procedure and their outcomes. And so he's a great resource as well. And he's very, very generous with his expertise.
So what's is it genetic testing is mandatory before, or are you just looking at the malformation? Okay.
Mandatory.
In terms of amniocentesis practice or CVS? Okay.
Yeah, usually we do a microarray.
Okay, great. Thank you very much. And for Dr. Eric, in our area, we cannot really send babies on caffeine at home because we don't have available home apnea monitors. So we have to keep the babies in the hospital for a certain time after we stop the caffeine to be able to discharge them home. But my question is that to you is, when you talk about evaluating babies' desaturation period, do you look at number of events per day, or you look at histograms and you look at a percentage of saturation below 80% for the 24 hours?
So the data that we're collecting, I think that's a great question. The data that we're collecting is really based on the histogram for the purposes of seeing whether later caffeine works to shift the number of events below a certain 85% or 80% saturation. And I think that to address the first concern about using home caffeine and needing to home monitor, I don't think that's necessarily clear. In the MOCA trial, the babies are actually being sent home without a home monitor and just keep receiving 28 days of caffeine once a day at home. And I think that the justification for that in the study was that we felt that this was a relatively low risk population for having apnea at home, and being treated for a full month would get them to a postmenstrual age that the risk of the caffeine being stopped and having them have breakthrough events was very, very low. And it's also true with the ICAF study. The babies are being sent home with a study oximeter, but that's masked to the caretaker. So it's not serving as a monitor, it's just a recorder. And so I think that it certainly is possible in certain categories of patients to send them home on caffeine without a monitor. And the other thing I would say is that because caffeine citrate is commercially available and is quite expensive, in the ICAF study, we're formulating a caffeine base, compounding it ourselves in the pharmacy. So it costs literally pennies per dose. So it's another way of approaching this problem if you decide that that's what you want to do.
Great. Just a word of caution for our audience. We have 780 colleagues are logged on right now to watch us live. So just a word of caution for our UAE audience. We have to follow the local guidelines for discharging home with caffeine or after caffeine, how many days according to your regulators. That might be different than the US criteria.
Yeah, we're a little bit more of a free-for-all, Dr. Amen. So as I said, there's a lot of variability. So I'd love to see your data about how consistent you are if you have national guidelines.
Yeah, great. And Dr. Junaid, do you have any questions?
Yeah, I have a lot of questions, but I start with Hafiz. This is my debate with him all the time. 14 days PICC line, and then you recommend remove it and put a new one. I need a comment on that, and I need a comment from our CHAPS colleague also.
Yeah, so as I said, when we looked at the evidence, there were two studies we relied on. There was a large study from the US, I can't remember the author now, from a network of around 3,000 babies, which showed no difference depending on the duration. Whereas there's another smaller study from Adam Milston, which said lines beyond 14 days, the risk of infection proportionally goes up. So I think it all depends on the environment we work in and the setup we have. And when we looked at our own data at Cornish, because of the peculiarities of the way we work, that was borne out. Our infection rates go up once lines lasted more than 2 weeks. And once we implemented the policy, it was a package of measures that is very difficult to pinpoint whether that was the only thing which contributed. We did see an immediate downward trend in CLABSIs as well as general infections. That's why we kind of stick to that. We are a bit nervous to kind of change it at the moment because we are still nowhere near ideal in terms of flow space, sensors, and other things. But certainly something which we are looking at closely as the evidence evolves.
Yeah, sure. Because we don't have CLABSI that much, and we have very small babies in my previous work. So I don't change, and I have no problem even with 24 meter if they are very sick and required more than that. Dustin, I have a question for you. What about, I know you mentioned about the COVID vaccination in a pregnant woman. Can you please elaborate? Because there are a lot of people WhatsApp me, they want to know, and they want to know in two ways. That if a lady get it, pregnant woman get it, a sign of harm. So she has to get the booster dose, or if she is in the late pregnancy now, so she has to get, the first dose, the second dose. What is your recommendation at this point when the COVID, I think, going down and this thing?
Yeah, that's another great question. I think the recommendation for the booster dose is so new that I don't think there's any clear recommendation for the pregnant population at this point. I think we will probably have some information or recommendation from the CDC, at least for the US population, in the coming weeks or months. I think your second question was about the timing of the vaccine.
Yes,
is that right?
yes.
Yeah, that's also a great question. You know, I think from what we know about data so far, and also from other vaccinations in general, that you need at least a few weeks for the pregnant patient to create the antibody and to efficiently transfer the antibodies to the newborn. And so I think my recommendation would be at least a few weeks before delivery, although so far the VSafe registry data from the CDC have shown that even vaccination in the first and second trimester is safe. And so I think it's really up to the pregnant patient and her provider to decide on the best timing.
Okay.
And one related question about, I know it's a little bit out of topic, but since we're in influenza season right now, so how about giving influenza vaccine to the mother in the same, what's the time frame to give it with the COVID?
Yeah, so the early recommendation was to keep other vaccinations separated by at least 2 weeks. And I think that was primarily to determine if there was any adverse effect or complication to not gray the picture of what was the cause. My understanding is that that is not a clear recommendation from the CDC at this point. And so I think providers are mostly still using that advice, although I don't think that's a clear recommendation. And so I think it's, again, up to the healthcare provider, but I don't think there's any contraindication to giving, you know, flu, Tdap, COVID, second COVID at the same time.
Yeah. Dr. Natalia and Dr. Holly, I am a neonatologist, a simple neonatologist, so I have a very simple question. What is your recommendation to take the baby for the surgery? When you say that this baby is stable enough for the surgery for congenital diaphragmatic hernia, because this is a long debate. As a neonatologist, we become anxious. Oh, now baby is okay. Take to the operating room, fix the problem. We will take care of later. So, what is your criteria that this baby can now go to the surgery?
So if the baby's not on ECMO, we almost never regret waiting until pulmonary hypertension resolves.
Okay.
So no spells, sturdy, you know, tolerating care, FiO2 weaned down to at least 50%, you know, not in this spiral of escalating care. The surgery doesn't like cure that kind of a situation.
Mm-hmm.
It sort of just makes them necessitate ECMO if you sort of drive in too soon. So I don't know, you know, we always go back and forth with this, and it's a very much a joint.
Yeah. We're always trying to decide. It's not the numbers on paper, right? We will check a BNP. We will look at the echo, but we use that in conjunction with how the baby's doing. So we'll talk about it all the time. You know, they're tolerating diaper change. They tolerated a suction. You know, someone turned the lights on and they didn't have a shunting spell. We really like to have that shunting kind of melt away, you know, really have that pulmonary hypertension. They're just far more stable and robust, but it's not like there are 10 rules that need to be accomplished. It's sort of big picture team discussion. Who are they? Where were they? Are they ready for the challenge of surgery? And so, yeah, if that answers the question.
Yeah.
We have one related question about ECMO. If the baby was very sick to go to ECMO and stayed on ECMO about 14 days, then after the 14 days, what's the decision? Would you go on ECMO longer time, or would you do surgery on ECMO?
We usually try to make the decision about, once we go on ECMO, we try to make the decision about whether or not we're going to try to get them off ECMO really early, and it depends on how they were before they went on. So if they were terrible before they went on, we're going to try to fix them on the early side, and so we're not going to wait 2 weeks. But if they looked pretty good and it was just purely pulmonary hypertension, cardiac dysfunction, then we're going to wait for that to get better. And then there's all kinds of tricks that Dr. Rantoul has for getting the lungs open, for keeping the fluid low. And we really don't give it a time limit. So it's sort of a week-to-week assessment. I think our world record is, you know, about 5 weeks on ECMO. But we don't like we We don't stop at 2 weeks just because it's 2 weeks.
Yeah, no, it's true. We look to see why they're on. Is it because the liver's up and the bowel is up or dilated and the tidal volume is like 2 mLs per kilo? Then it would be like, well, we have to start then to plan for the surgery to try to get some space to come off. If the lungs are wide open and the tidal volumes are 4 per kilo, maybe 5 per kilo, but every time we wean the flow, that pulmonary hypertension rears its ugly head and then they're shunting and the right heart is struggling, then we'll start them on that treprostinil and start to ramp up over several days and then see how they respond. And so it's, do they need a repair? Do they just need more pH meds? Do they need more time? As always, Dr. Hendricks was saying, time is the best medicine, right? Sometimes they're not ready at 14 days, but by 21, they're like a totally different patient. So it's again, who are they at that moment? Are the lungs open? Are they edematous? Is it pulmonary hypertension or is it the size of the lungs? Is it the size of the liver that's impacting their whole picture? So we always say every phenotype is so different. We treat each baby different. But really, there was an early paper by our colleagues in Pennsylvania that looked at pulmonary hypertension, and they didn't see any survivors if they had significant pulmonary hypertension after 6 weeks. So that's sort of one of our things. We think, we start thinking by 2 weeks, then by 3, by 4, we had one patient that survived at 5 weeks on, but it was significant pulmonary hypertension. And so, we try to look at the whole picture and try to assess what piece of it is it that we're treating and what needs to be done.
Yeah. I have one question for Dr. Akinwal. Dr. Akinwal, I know your topic is when to stop the caffeine, but I want to discuss among all the colleagues, Hafiz, Dan, Dustin, and yourself and Eamon, that what is the dosage? How maximum dose you use? Yesterday we have Dr. Ben Clary and he talked about 20 milligram per kg. What is your experience to use that high dose? We never use here, and I think same with Eamon. Here is working with us here in Abu Dhabi. So, what is your experience?
So no, I think that's a great question, Dr. Junaid. I think that we only use up to 10 milligrams per kilogram per day. We really stick with what was studied in the CAP trial, and I think that there is some controversy. There are some studies, some randomized trials that demonstrate that Dr. Baccalaureate, I'm sure, reviewed that the 20 milligrams per kilogram as a daily dose does have an effect on decrease in apnea and maybe increase in extubation success. But my concern with that is that the safety of that has not been studied. And it's primarily being used in the very, very preterm babies, which again were underrepresented in the CAP trial. So I think that our first approach to this should be what's been proven to be safe, and that 10 milligrams per kilogram has been proven to be safe. So we don't go above that. And I will say that Dr. Barbara Schmidt was our colleague here at CHOP for a decade. And as I'm sure as I listened to her talk, she made it very clear that she's on the side of evidence-based medicine. And right now, I think the evidence would support the drug doses that were studied in the CAP trial and not higher. So I would be hesitant in my own practice. And I know that my colleagues at CHOP and Penn would be hesitant to go any higher than that right now without further data on safety.
One follow-up question about the dose. Now, if you have a baby on 10 per kilo and you decided to stop caffeine, would you go down to 5 first, or you go just 0 from 10?
Personally, I would just stop it altogether. I mean, I think that the drug levels are going to be slightly higher on 10 per kilo than on 5 per kilo. Some clinicians decide what they say to outgrow the dose, where they allow the dose to become lower and lower on a per kilo basis as the baby grows, which I think is an okay approach as well. But I don't think there's any real data that you need to wean caffeine. If you're ready to come off, I would just simply stop it. And then you have the advantage of monitoring for spells. You'd expect them to increase a little bit afterwards. but then as the drug disappears and the baby gets older and more mature, that the apnea should resolve.
We have a question for Dr. Natalie and Holly about if a neonatologist decide, or actually fetal-maternal doctor decide to refer the patient for possible fetal surgery, would it be possible to be evaluated by telemedicine, or the patient have to come to Philadelphia to
I think ultimately, if it was a serious referral, like we would be happy to review the images, happy to have a conference, but for a true evaluation to be sure they were a candidate, we can't really promise anything unless it's in person. So we're happy to review images, to consult with people ahead of time, but it's not until it's hands-on, it's not a true sort of recommendation.
But we have been doing a lot of teleconferencing, especially after COVID started. We really ramped that up, and very frequently we do have, group meetings with referring places, and whether it's the moms prior to surgery or even for, help with babies down the road. We've been doing a lot of that too. So if anybody needs anything.
Evan, I have one question for Hafiz. Hafiz, we discussed a lot, and I discussed with Dr. Poland and one time with Dr. Eric also. Let's say you have you suspect CLEPSY. Did you culture from the central line, and did you send the catheter tip for the culture?
We don't do, the central lines we put in our 26, 28 gauge lines, which rarely bleed back.
Yeah.
So unless it's a femoral line or a Broviac, they don't get blood back. So if we have a Broviac line, we certainly do a culture from the central line. Otherwise, it's peripheral cultures, which we do. And if we suspect a line is infected, we don't send tips routinely. If we're just taking out a line because it's time to take it up, we don't send it routinely. We don't find it useful if the baby is well. But if we suspect, we don't know where the source is, and we've taken out a line in an infected baby, sometimes we send it, but not as a routine.
Dr. Eric, I don't know if you remember, but it's actually me, Evan, you, and Poland, Dr. Richard Poland discussed this. Did you send for diagnosing the CLEPSY central line culture from the central line? Because Dr. Poland said the two different peripheral line you can send, peripheral culture you send. What is your practice and experience?
So I'll defer that question to Dr. Dustin, since he's an expert on neonatal infections.
Okay, that's right. Sorry about that. I didn't know that.
I can tell you what we generally do, but
My apologies.
we usually at CHOP we send a central line and a peripheral culture, both. But I think Dr. Dustin can go through sort of what the other official recommendations. And as you know, I would never cross what Dr. Richard Poland says. But sometimes our practices are a little different. But
sure.
Dustin, I'll let you respond to that, Dustin.
I think he's listening to us, so.
Yeah. Yes, Dustin. Go ahead.
I'm not sure there's an official recommendation, but I agree. I think the best practice would be to send both. Unfortunately, in some scenarios, it's just not possible. If you have, a 23-weeker, and you're not able to draw back from the line, or you're not able to get a peripheral stick, or you only get a quarter cc from each, you may just have to send what you can get. But I think in an ideal world, you'd send from both sites, aerobic and anaerobic. But I just don't know that that's always feasible.
Okay.
But we all, I think, agree that we don't want to send the tip of the catheter. It's a big line removed to a culture. I think.
Yeah,
I think we all agree. I think
unusual for us to do that.
Great. So I got a signal that we have only 2 minutes left before we close. So I will open the floor for anybody who want to ask questions, because we're asking all the questions. But if you have any question to ask anybody here, will be great.
Can I ask a question, Dustin? Thanks for the wonderful talk on COVID. We've done a fair bit of work at our center as well. One of the things, we haven't published this data yet, anecdotally what we're seeing with the second wave, where the Delta variant was more prevalent, we were seeing much more sicker moms, much more placental pathology. Is that your experience as well as compared to the first wave?
Anecdotally, absolutely. I think early on, there was a lot of fear about how the virus would affect pregnant patients, but it definitely did not seem to be as severe as we had feared, as with influenza. But just anecdotally, and I don't have research data to support this, but over the late summer, especially in August, at our own center, we had multiple cases of pregnant patients admitted to the ICU, mechanically ventilated, transferred for ECMO. And that's certainly a national trend in the US, which again was the cause for that urgent health warning from the CDC at the end of September. And I wanted to make one clarification about the timing of the COVID vaccine that I should have mentioned. The timing recommendation for influenza is any time during pregnancy. And that's not just to optimize antibody transfer to the newborn, but really to protect the pregnant patient, because we know that pregnant patients are at high risk for severe influenza, as opposed to Tdap, where the Tdap recommendation is for later in pregnancy to really optimize antibody transfer because pregnant women don't get sick from pertussis. But as this Delta variant has changed our understanding of how COVID-19 affects pregnant women, I think the recommendation will probably be to get it as soon as possible, and certainly ideally before pregnancy, to really protect the pregnant patient.
Anybody have any questions?
Thanks.
I would just like to compliment Dr. Hafis on his work. I did say that in the chat, but I think that quality improvement extends certainly internationally, and a lot of the work that he's done in his unit is work that we've all done in our units as well. So it's gratifying to see that it can work as well all across the world. So that's I think a lesson for the people listening here, that you really can make a difference and improve the outcomes of the patients that we take care of.
Maybe we can do a multi-center project together to
yes, exactly. And Dr. Eric, he was my competitor. So he did this transformational event and he won the first prize and I come second. So I'm really, but he's like my younger brother.
You have to be second sometime,
Yeah.
No, very well done, Hafiz. Very well done.
Now, since 3 of the 4 speakers are from CHOP, I don't have any questions for them because I can see them on a daily basis.
Okay.
But,
very good. Thank you
but I
very
think
much. We really enjoyed this session. It's really great closing for the conference. And as Eric mentioned, we will hope to see you, and inshallah we'll see you next year, mid-year. I'm not going to give you the exact date yet because we haven't decided, but mid-year we're going to have a hybrid conference. So we will be happy to see you in person, inshallah. Thank you very much. Appreciate your sharing with us all your knowledge and wisdom, and then we will see you soon, inshallah.
Thank you.
Thank you.
it's
Thank
good
you
to see
very
you all
much.
again.
Take
Thank
care.
you.
Thank you. So. So thank you very much once again to all the speakers, all the participant delegates to have this comprehensive Congress. This is really very much fruitful and thoughtful Congress. A lot of question arises, a lot of quality improvement, and a lot of good projects we learn with these 3-day Congress. That's very well attended. That's all from my side, and I will like that my friend, my colleague, Dr. Ayman Rahmani, should close the conference and give his closing remarks. It's all the best, and see you in the mid-year with that kind of a conference again. But Dr. Ayman will do the closing remarks. Dr. Ayman.
Thank you. Okay. Can I go live or no?
Yeah, you are live.
Live.
Oh, okay. Thank you, Dr. Junaid. Really great closing and a great conference. And we actually have a record number of participants this year, up to almost 4,000 registered. And until the last minute of the conference, we have 780 participants joining the discussion and the last session. So it's a really great conference. First of all, I would like to thank MENA Conference for putting together great organization, all the staff, Dr. Khalid Afifi, and everybody who participate in organizing this, especially Zandi. And we will, inshallah, we'll see you next year in a hybrid conference, mid-year next year. This year, we have a really great program, but we cannot really underestimate your feedback, because your feedback will give us what you would like to see next year, what topics you want to see and hear about, and your feedback about all the presentation this year, and what else we can do to make this conference much better. Thank you very much, everybody, for staying with us for the last 3 days. And I hope that we will see all of you next year in both in person and online. Thank you very much, and have a good evening, everybody. Morning or evening or afternoon.
Thank you. Thank you very much.
And on that final remark from Dr. Ayman, we have successfully concluded the 11th International Neonatology Conference. First of all, we would like to thank our roster of international and national speakers for gracing us with their knowledge and perspective on the latest topics in neonatal medicine. Your work, insights, and studies are truly remarkable, and we wish you the best in your future endeavors. We would also like to acknowledge the following companies who participated and supported this event: Children's National Hospital USA, Children's Hospital of Philadelphia USA, Shesi Pharmaceuticals, Sobi Pharma, and Roche, and Prolacta. We thank you for your engagement in this scientific virtual gathering. We always appreciate your support, and we hope to continue this partnership in the future. To the members of the committee and advisory board for your commitment in delivering quality content on neonatal medicine, may you always strive for the best. And last but not the least, to our attendees, for your continuous viewing, we hope you have enjoyed the lineup of sessions, topics, and speakers for this 11th edition of the conference. And we look forward to your participation at our future events. On behalf of MENA Conference, this is Lane DeLumen, your host, wishing you all a peaceful evening. Thank you and good night. you.